Hi, everyone. Welcome to my presentation. It's called Give Your Patients What They Want, Precision with Speed. My name is Dr. Esther Feldman, and we're going to get started. All right, so before we start, everyone make sure that you're signed in on the attendance sheet to make sure you can get your continuing education credits. And I have to go through this disclosure. I am not employed by any dental companies. I do not own any stock, securities, or interest in any said dental company. A family member, immediate or extended, is not employed by or owns any stock, securities, or any interest in any dental company. And I have consulted or evaluated products for the following organizations: Propel Orthodontics. As a disclaimer, hang on one second. Sorry. I have been compensated in the past for consulting and or evaluating products for the sponsors, including Propel Orthodontics. For my participation in this event, I have received an honorarium from Propel Orthodontics. The opinions expressed in this presentation are my views and may not necessarily reflect the views or policies of the sponsor. The materials provided are for educational use and not to be used for advertising or product endorsement purposes. This presentation has been approved for continuing education credits. No photographs, videos, or audio recordings are permitted during the presentation. So I'm going to introduce myself. So I'm from Montreal, Quebec, Canada. So I'm perfectly bilingual in both English and French. I also understand and speak some Hebrew. I graduated from McGill University. I was there for 7 years. I got my bachelor's degree in honors degree in anatomy and cell biology, and then did my doctor of dental medicine there as well, graduating in 2011. I then went on to do my orthodontics degree at University of British Columbia in Vancouver. So I'm totally Canadian trained. I got that, it was a dual degree, a diploma in orthodontics and a master's in craniofacial science, graduating in 2014. I was that school's second graduating class. And then I got my diploma of the American Board of Orthodontics in 2015. And I'm also board certified in Canada as a fellow of the Royal College of Dentists of Canada. I moved to Los Angeles upon graduation and started my solo practice out here about 18 months ago. I have my master's thesis article published in the American Journal of Orthodontics, and my hobbies include yoga, Pilates, and skiing. I live quite an active lifestyle, so LA has been really good to have both of the abilities to do outdoor sports and be outside all the time. All right. So a little bit about my practice. I have a very unique type of practice here in LA, very, very personal office. So I'm in West Los Angeles, which is a more affluent area. I'm around a lot of private schools where the tuition is upwards of $40,000 a year. My practice has 3 chairs and 2 staff. Both of my staff are cross-trained, so they can both do front and back. It's a fee-for-service office. I am not in network with any dental plans. I do submit claims out of courtesy for my patients, and it's really personalized care. So my patients see a lot of me. I will give the investment presentation to the patients. I get to spend a lot of time with them, and that's what's creating the internal referral mill for my office. So this is just a picture of my 2 girls, Rosie and Jarelli, my right and left hand, as I like to say. And those are pictures from my open house party, which took place in November of 2018, sorry. And my Invisalign Jello shots were a really big hit. So not the easiest thing to drink, but definitely look really pretty and were a big hit with all of my referring dentists. So I'm going to get into some of the nitty gritty here. So we'll talk about the science behind micro-osteoperforation, also known as MOPs. So we all know about bone remodeling back from our school days. So we know that the bone turns over naturally. It's always turning over. So osteoclasts are going to be the cells that are going to eat away at the bone. And then the osteoblasts, which are the bone creating cells, are going to come in. They're going to lay down some lining cells and allow the osteocytes, which are the bone cells that actually secrete the bone, to come through. So this process is continuous It's always happening, but the rate's going to depend based on our patient's metabolisms, and every patient is different. So the way that the teeth are going to move is going to be dependent on the rate that the bone is remodeling, allowing those teeth to move through the bone. So what MOPs are doing, the acceleration strategy, is that it's targeting this process to increase the rate of remodeling, to make it go faster while we're keeping our magnitude of force the same. And it creates what we call a regional acceleratory phenomenon, or RAP for short. And what we get is much faster bone remodeling that lasts about 4 months once this is stimulated. And that's going to help the teeth move faster and the treatment progress much faster. So MOPs target the rate of remodeling. So we know that when we stimulate the bone, we're going to increase the cytokine levels. We're going to reduce the bone density, and that's very temporary. When we say decrease bone density, it might sound scary to some patients, so I wouldn't necessarily say that. But what we're doing is we're stimulating it to increase the rate of bone remodeling, help the bone change shape faster, which is going to help the rate of tooth movement happen faster. And that research is all the way from 1985, the year I was born actually, and 1988. So looking at a study that was a randomized trial, they showed that MOPs are effective, well tolerated, and also a very safe procedure. So this is something that is minimally invasive, but as an orthodontist, we're not used to taking out something that's going to cause blood, use local anesthetic, all of these things. As we're doing them, we have to make sure that we're reiterating to a patient that this is a safe procedure and that the benefit definitely outweighs any of the minimal risk that's associated with it. And that also, I love giving patients numbers because it helps them understand better. So just telling them this is going to make your treatment go by more than 60% faster is going to help them really get on board and make them really excited, because everyone's always asking how much longer, how long is this going to take? Anything that we can do to make it go faster is really going to help motivate the patient. So there have been newer studies. That one was in 2013. This one was actually published in 2018. And it looked at the rate of tooth movement and pain perception during accelerated tooth movement associated with, it was fixed appliances and MOPs. And what they saw again is that the MOPs were really well tolerated and that it was such a significant acceleration of tooth movement. The pain level was not increased at all. Patients were really happy, and they actually said that it was a good experience. So now looking at the difference in the devices that we can use to do these MOPs, there's a manual driver that's autoclavable that has 2 tips. I've used this driver before. It's much harder and more physical, especially on the wrist, to engage the tip into the bone versus the newer motorized one, which again has an autoclavable tip. And the speed is adjustable, the torque is adjustable. So you set everything before you get started. It's so much easier to use, so much more seamless. And I also think it's a better experience for the patient. It's not very loud when you're using it. The tip engages really quickly, and it allows you to move much faster between each MOP that you're doing. So it's made out of high-grade surgical steel, so no risk of fracture or separation during an appointment. It's really great. It's really changed it. It used to be much harder with the manual driver. So this is an FDA-approved device to use and procedure, which is also something that really comforts the patient when you let them know that. You can use MOPs with any type of orthodontic treatment, aligners, braces, RPEs, anything at all. You can use it for any malocclusion at any point in treatment, and there's no compliance necessary. You do it when the patient's in the chair, and that's pretty much it. It leads to faster, more predictable movement. You can use it in any area. So if you wanted unilateral expansion, you wanted to accelerate treatment on one side, you would use it only on one side. If you're having trouble closing a space on one side, you would just perforate on that side. Root protective, so it's what that phenomenon of reducing the bone density in any given area helps the tooth and that root move through the bone much easier, which can help reduce root blunting. Less pain because there's less the remodeling is happening much faster and it's stimulated. And I think the biggest advantage of the whole thing is that you're getting through things much faster. Patients aren't burning out. So the ideal finish is you're going to be able to get to faster because patients aren't complaining as much about when am I done or take these braces off. So this is just to illustrate that root protective. This is obviously a huge movement. So if patients have very dense bone and different ethnicities, you're going to see the bone's going to be different. The way the teeth are going to move is going to be different in an African American versus a Caucasian person, an elderly person versus a younger person. So we always know that root resorption is a risk in treatment, especially with torque. So if you're using sound mechanics and you're using MOPs, you're going to decrease that bone density in that localized area. That's going to help give you the assurance that you're not going to lead to more root blunting or any issues in that area. So as for the procedure, it's really simple. You always are going to need some radiographs of the areas you're going to be perforating. So whether it's a full mouth series, a pan, whatever you need, you're going to palpate the tissue as well. I often like to even mark with the tip where I'm going to perforate. Just make sure. You can often see through the gums, make sure you're between two roots and that you're in the right area. I have my patients rinse first for 2 minutes with chlorhexidine. They only have to rinse prior to the procedure, not afterwards. And then personally, I like to use local anesthetic. So I'll put some topical. I know that BTT is an option. I don't use it, but I just use some lidocaine. I infiltrate. I don't use more than a carpule per arch. And that's usually more than enough to get the patient anesthetized for this quick procedure because it doesn't take more than 15 minutes an arch to do all the micro-osteoperforations that you need. And then based on the targeted area, I usually will have it marked on my chart beforehand if I'm doing specific areas or if it's more of a generalized procedure. And then you just go to town, do your procedure. So one thing that I want to clarify is that with MOPs, we're not just creating a hole. What we're doing is when we engage the tip into the bone, it's creating these little microfractures. And when we do that, when we use this compressive stress on the bone, those little microfractures radiate about 6 to 10 millimeters away from that center. And that's what's changing the bone chemistry. So we're getting that effect in that entire area just by making that tiny little micro perforation. So here are some frequently asked questions. So the effect is regional, very localized. I always explain to my patients that when we're doing Propel or when we're doing micro-osteoperforations, we're trying to create a local inflammatory effect. So it's not anywhere beyond the mouth, but by doing these tiny little perforations, it goes about 10 millimeters max in radius from that point. It's usually about 1 to 3 MOPs per site, depending where. Lower incisor area, often there's not a lot of space. You're going to want to stay away from any frenums. So some areas get 1, some 2, depending what you're trying to do. If there's a big extraction space and you're trying to speed that up, I'll sometimes do even more than 3 MOPs in that area because we know that the remodeling is going to be proportional to how many perforations we place. In terms of the depth, we're not trying to go very deep. The depth is shallow. It's not the same as placing a TAD. You're just trying to engage through the cortical bone. You're just trying to use that compressive stress that's going to get you those microfractures. So in my office, I present treatment to patients. I present the investment as well. And I always talk about, I would say about 90% of my patients I present Propel to. The 10% that I don't are either teenagers that are going through their growth spurt, that their metabolism is fast enough that I don't even need to go there. And then the high anxiety patients, I just don't want to introduce anything to those patients that would give them more anxiety as it is. But I would say this is such a simple foolproof type of procedure that it's really such a gift to be able to present it to your patients because it makes treatment more predictable and way smoother. Those difficult movements, this really just helps get those unpredictable teeth like those big canines or the molars or any, torquing that you need to get. It just helps so much with all of that stuff. So when I present MOPs, again, when I described my demographics, I'm dealing with mostly professionals and educated and an affluent population. So it's always an add-on to treatment. It is a premium option. So I always like to set expectations. I want patients to know exactly what's coming if they do opt for that, because it always sounds so appealing to say that it's 60% faster. I like to compare it to acupuncture. I just tell them it's intraorally. So I'm stimulating the bone with a very thin stainless steel tip, similar to an acupuncture needle. And you'll have these little, you won't be able to see it in a couple of hours. It's just going to heal up. And then I also just inform them that sometimes it will have to be repeated. It might not be a one-time procedure, depending on the movement, because we know it's good for about 4 months. I also explain them that this is how much it costs in my office. So it's either $450 per quadrant or $1,200 for the full mouth. I also like to emphasize that it's a minimally invasive procedure. There will be some minor discomfort when I am using the local anesthetic. It's a lot, especially when I am doing the whole mouth. So I want to make sure that they're aware of that. They will be fully numb. Other than that, I really emphasize, again, it's 60 to 70% faster. And depending on what their cycle is, if it's aligners, if it's braces, I will be seeing them more often. If they're in aligner treatment, they're going to start with 3-day changes immediately after, and then move on to 4 days, 5 days, depending, instead of 7 to 10-day changes. Again, it depends on the movement that I'm trying to achieve in the specific patient. So these are just catchphrases that I like to use. So I did treat my mom and my fiance with MOPs. When I treated my mom, my dad was assisting me. It was pretty funny, but it was well tolerated. And I always tell my patients, I have a great relationship with my mom and with my fiance. I love them both. And this was something that I wanted to do for them because I knew it would lead to smoother, better treatment. I also let them know I use less anesthetic per arch than for one filling. There's no downtime. You don't miss a meal. As soon as the anesthetic wears off, which usually is by the time they leave the office, because I'm doing so little with each infiltration, that they can go back to work. They might be a little bit sore, but nothing that Tylenol can't fix. I really emphasize, again, the more predictable, seamless treatment and that more frequent aligner change or more frequent visits with braces. This is a video, did a time-lapse video of a patient having MOPs in my office. So just from the patient experience perspective, which is something I really like to focus on. I really want my patients to have an amazing experience in my office. You can see this patient is smiling. I even went back and I had to get my local anesthetic needle one time because he was feeling it a little bit. I'm going to play it one more time. I wanted to make sure that he was totally comfortable the entire time. My assistant will always stand by me. She just dabs at it with a 2x2. There's usually no residual bleeding, and by the time the patient leaves, they're totally fine. The numbing is wearing off, and I give them 2 Tylenol as soon as I'm done. All right. So this is what it looks like. 30 minutes post-MOPs. You can barely see between the upper left canine and premolar, there's 2 tiny little perforations. I mean, it's so not scary when they see these images. Even though they are going to be numbed, even though they are having micro-osteoperforations, they're so small, they heal so quickly, really minimally invasive. So my post-treatment, I always again, want to set expectations. I don't want any patients feeling surprised. So I tell them that any sensitivity that they might feel after is going to be similar to having an orthodontic adjustment or putting in a new aligner, just feeling a little bit of pressure and tenderness. So it's going to be normal to feel that for the first 24 to 48 hours after the procedure is completed. And I always recommend Tylenol and tell them to stay away from any non-steroidal anti-inflammatories, no Advil, no Aleve, no Motrin. The whole point is to create a local inflammatory environment to help with the bone remodeling. We don't want anything that can potentially get in the way, anything that can potentially slow it down or counteract that movement. So I'll present a couple of my cases where Propel was super dramatic and really helpful, and I had super happy patients. So this is a 60-year-old male that came to me, and he really wasn't doing it for the cosmetic purpose, but he felt like he was claustrophobic in his mouth. He felt like his tongue space was being impinged on, and you can see how constricted his arches are. He's class 1. He has a division 2 appearance. His laterals are forward of his centrals and they look more prominent. You can also see that deep curve of spee, and you can see that lower gum architecture where it goes from canine to central, that it's all wavy. So when I presented Invisalign to this patient, and because he was not wanting to have braces, we talked about all the other things that we can do to help make it faster, because we had some difficult movements, that lower right canine, that upper left lateral, the upper canines, and all of the expansion that we needed, and he jumped on board right away. So this is his panoramic X-ray. That lower left molar looks like it has a short endo, but it's asymptomatic, and the general dentist told me to go ahead. So some of the considerations for this case, I did treat him with clear aligners. I knew that we were going to have some difficult movements. We had a lot of arch development, a lot of expansion to do. And he really wanted to, finish faster. And he was totally on board for having micro-osteoperforations to help with his treatment. So if you look at him at 3 months, we've had a lot of progress. You can see how nicely the upper arch is aligned. The lower has improved too, but we still have an issue with that lower right canine that's not tracking so nicely. His bites opened up a lot. He's really happy. His smile line has changed. And this is just a close-up again of like the upper arch. So if you look at that upper right, especially the lateral and the canine, they've moved a lot, the upper left canine. And this is in 85 days. So while that lower right canine has moved, I didn't feel like it was tracking exactly the way I wanted to. So I actually repropelled that one tooth. So this is him with a lot of staining. He's a big tea drinker. But you can see that that lower right canine now, if you look at the lower arch, the lower occlusal view, that lower canine has really come in. And this is, I think this is 3.5 months. This is a month later. I wanted to keep an eye on that lower canine just because he wasn't tracking, and it's looking so much better. And this patient is now in his refinement, and he'll probably be done in 6 or 7 months total for this treatment. And if you look at his smile line now, he's so much fuller, whereas he used to be so constricted and have these wide buccal corridors. It's looking so much better, and he's thrilled, and he's sending his friends and his family. And now this case. So this is a 32-year-old male. He was referred to me by an oral surgeon. So if you look on his upper occlusal, you can't see the wisdom tooth on the right, but his upper right 7 was extracted because it was hopeless. And the oral surgeon sent him over to me and said, is there any way you can protract his upper right wisdom tooth instead of having him need an implant in that site? And I said, sure, well, let me try. So he's got a lot of crowding, but he's also really constricted. He came in, he was laughing. He's from England, and he's like, it is true what they say. British people have the worst teeth. And he wasn't that self-conscious about it, but he was definitely motivated. He has a non-extraction profile, although he has a strong chin. I really wanted to try to see if with just some IPR and some expansion, if we can resolve this crowding and get that upper right wisdom tooth into place. So this is the panoramic X-ray, and you can see that even the first molar is already compromised, but that second molar is hopeless. So this was taken out along with the other 3 wisdom teeth. So some considerations for this case. He only wanted to be treated with clear aligners. That upper right 7 was extracted, and the goal was to close the space. He wanted to unravel the crowding, reduce his deep overbite, align all of his teeth, and develop those arches because they were super narrow and parabolic shaped. So this is him at 2 months. And now you can see where that upper 3rd molar is. It's really coming in. We had a 12 millimeter space there when that upper right 7 was extracted. And that tooth is tracking beautifully. Granted, I have some large attachments, both on the buccal and the palatal of that tooth. It's really coming along well. It's tracking perfectly. We did general propel here, propelled everywhere, and really went to town in that extraction site. I probably did like 6 different micro-osteoperforations in that area. And his teeth have aligned significantly. Again, we still have some problem teeth and some teeth that I really need to make sure are tracking, but this is a huge change. So now I'm going to show you at 3 months. And now look at that 3rd molar. I have about 2.5 millimeters of space left to close in 3 months, what was a 12 millimeter space. His wife is actually a famous actress, and he was laughing when he came in because he told me that she has me in her bad books because now he's getting hit on when they go out, and he never used to because his teeth were so horrible. So if you look at his bite right now, his overbite has reduced significantly. We're still aligning and leveling, especially in the lower arch, but his upper it's night and day, just so much better. And he's so happy. He's thrilled. So, I'm just happy that I'm able to protract that tooth and not keep him in treatment for 2 years plus to be able to get that tooth into alignment and next to the upper right 6. So here's a 3rd case, and this is a 29-year-old female who came to me, and she was suffering emotionally from her smile. She felt that she hated smiling. This is after her wedding, and she told me that, she noticed in all of her pictures that she wasn't giving a full smile because she hated her teeth so much, and she wanted orthodontics. So when I worked up her case, this is her pano and her ceph, I was looking at her teeth, and I felt like on the upper arch, I had to extract. And when I was looking at my options, I noticed that her upper molars really didn't look good. There seems to be, especially on the upper left 6, on the mesial root, there's still a lucency, large overhangs on both, especially on the upper right 6, on that crown, and the endos just didn't look good. So her general dentist told me that they were totally on board that everything was going to have to be redone there. This treatment was done in Russia about, I think she said 10 years ago. And I said, you know what, if I'm going to extract 2 teeth, I would rather take out 2 compromised teeth and not 2 healthy teeth. So we elected to take out her upper 1st molars and treat the lower non-extraction. I did also talk about needing to use a TAD on the upper right to be able to retract that upper right canine into class 1. Let me go back to her pictures because the upper right was more class 2 than the left. And I told her about micro-osteoperforations at the very beginning, but I said, let's see how things go, and then we'll decide, because we did also have a large 12 millimeter spaces bilaterally to close. So we used fixed appliances for her. And at 16 months, I had gotten some closure already, but she was starting to burn out a little bit, and she said, you know what, let's talk about those micro-osteoperforations. And I did them just in those extraction sites again, which is really easy because it gives me a lot of area to work with. And I did my perforations in those areas. You could see my little hook on that mesial to the upper right canine where I was using the TAD to help pull. So she was retracted into class 1 on both sides at this point. And after her MOPs, you can see I had bunching of gingival tissue in that area. And this picture to me really illustrates the power of MOPs and how amazing they are, because her tooth moved so quickly after those MOPs that her gingiva couldn't catch up. Her gingiva bunched up and formed this physical obstruction between her premolar and her second molar, where I had to send her to the periodontist to excise that tissue so that I would be able to close the rest of the space. And this was like 2 to 3 weeks after I had done the MOPs procedure. So this is her at 22 months. At 22 months, she was finished. She was burnt out at that point. She just said, get them off, I'm done. But let's look at her smile. Her smile's completely changed. We got her midlines on. She's in class 1 on both sides, and we closed that 12 millimeter space. And what I had told her was going to be probably closer to 30, 36 months took us 24 months. So I actually think it was 22 months. It was just under 2 years when we finished. This is my last MOPS case. So this patient is a 36-year-old male. He's an architect. He's traveling all the time, and he came in. He's Irish, and he said, it's about time. I need to fix this. He's in unilateral crossbite on the right side. You could see on the lower arch, especially on the left side, how lingually torqued his lower molars and second premolar are, and he just also very collapsed arches. So he wanted only to be treated with clear aligners. And given his schedule and his timeline, I presented micro-osteoperforations as an option for him. And this is him 5 months later. He went through all 52 aligners. He tracked the entire way through, and he looks like a different person. His teeth fit together. We're just out of crossbite on that right side. He told me he sleeps better, he breathes better, he's thrilled. And now we're starting his refinement, and he's 5 months into treatment. I mean, looking between these two, it's really, this is to me like these examples of how much arch development you can get and how quickly you can get these changes. This is what sells, you know, what these patients basically do my job for me when they refer other patients over. So the patient reactions that I commonly get after this procedure is, that's it. There was only slight discomfort. It's not painful. You know, there's just some soreness, but it's not painful. I've had patients say it feels weird, but it's definitely not something that hurts. One patient told me the only negative part of it was the numbing, you know, and that's kind of common in the dental world to be numbed for procedures. And every patient across the board has said it was so worth it, and they would do it again. So now I'm going to switch gears, and we're going to talk about high frequency vibration. So this is the V+, and we know that the VPro 5 and the V+ are both FDA approved as aligner seeders. So when I present this to my patients, I present this to everyone, teenagers, adults, everyone gets presented with this. I tell them about all the benefits because it's so simple. It's conservative. It can help reduce pain. I've had patients say it even soothes them. They like to do it because it makes everything more comfortable, reduces refinements. We know it increases tracking with clear aligner therapy. It's going to reduce treatment time. It's going to reduce root resorption. It's going to help us with our bone remodeling. And it's also very synergistic with MOPs. And we now know that with retention patients, it helps increase bone density. So I like to even tell them, it's not something that you throw out after treatment. You're even going to use it when you're in retention because it's going to increase your bone density while it's there. So it's one of those appliances that's good forever. So the science behind vibration, this has been studied for a long time, and we know that vibration and bone biology it works. So historically, we know, and there's still research that's coming out today, that bone cells are very responsive to mechanical stimuli. So they're very responsive to these high frequencies, and that's the science behind the VPro. So I'm going to present some preclinical research. So a 10-year methodical investigation came out, and this was shown without orthodontic force. So it was just looking at high frequency on the alveolar bone. And what it showed was that 100 hertz and higher they showed significantly greater bone density. Then another study, again, and these are all in vitro studies. They were looking at orthodontic force, without orthodontic force, after extraction cases to try to prevent bone loss, and they found that it was 120 hertz that was the significant differentiating frequency to help prevent bone loss. And finally, this last one, which is the most recent from 2018, was one that was done with orthodontic force, and it also showed that 120 hertz was the number that significantly increased tooth movement. So this is all evidence for higher frequency vibration being positive for bone density and tooth movement. So now some of the human clinical trials that were done. So the in vivo trials. So they're just confirming and building on that preclinical in vitro research. So this study is showing us, so it looked at the differential efficacy of two different vibrating orthodontic devices. So one was Cellular, which is a low frequency vibration, versus the VPro, which is high frequency vibration. And they looked at the different cells in the PDL, the periodontal ligament, how they responded to these different vibrations. And what they found was that 120 hertz was producing greater cellular proliferation across all of these different cells. Then we had this study which looked at the effect of the application of high frequency vibration on tooth length. So it was looking more at root blunting, and it found that at 120 hertz, there was significantly greater root preservation versus at 30 hertz. And finally, the last one was looking at the effects of brief daily vibration on clear aligner orthodontic treatment. And this one showed that 120 hertz significantly improved aligner tracking. So the patients that were using the 120 hertz were tracking overall better, and their treatments were going through. So I'm going to look at one of the in vitro studies, and that one looked at the vibration low versus high, and it was looking at the cellular activity. So what this is doing is it's actually, if you look at, there are these little cell culture plates, and you could see the low frequency, it's an Cellular that's attached to these cultured plates versus the high frequency, which is a VPro. And on the top, there's this little accelerator it's measuring the acceleration force. And what they found was the peak accelerations generated by the VPro 5 versus Cellular were 70% greater. And then they found that the greater vibration frequency peaks, they showed that there was greater cell proliferation in the VPro versus the Cellular across all the cells in the periodontal ligament. So the osteoblasts, the fibroblasts, everything was way more expressed. And they concluded that the difference in vibration profiles was striking between the two devices. One was way more efficient than the other, which we know is the high frequency vibration was showing all of this different cell expression. So there was a landmark trial in 2018 that also spoke about this low versus high. And the high frequency identified had dual mechanism of action depending on use in active treatment or retention. So this is that anabolic and catabolic effects. So what they found was the different frequencies, they are going to have different results. So all of this is looking at the periodontal ligament tissues. And high frequency significantly increased the rate of tooth movement versus low frequency. So this was an in vitro study, but what they saw was that low frequency versus high frequency is going to lead to much more tooth movement. So again, everything is pointing towards high frequency vibration. And I love this example, courtesy of Dr. Thomas Shipley. He showed a patient who came in, finished treatment, was well aligned, and they relapsed. They were not compliant with their retainers. And what he did was he had them use a VPro in the office to try to get it to seat. And that patient wasn't even able to place their Vivera retainer in because it was so uncomfortable because the teeth had shifted so much. And after using the VPro every day, it fit perfectly. The teeth moved back. The seating was totally improved, and he got the referrals from that patient's sibling and probably from that family in general. So it's just showing you the power of having something that can help. I always tell patients it's jiggling that aligner. It's helping force it in over the teeth. Teeth have a convexity to them. We need something that's going to help push it on. And the problem with chewies or with other things that patients can chew on is that it can distort the tray, whereas a device like the VPro 5 is never going to distort the tray. If you hold on to it while it's vibrating, you'll feel that high frequency vibration is not something that's going to make their head shake or anything like that. It's not that strong a force. It's a high frequency, but it's not aggressive at all. So high frequency vibration is definitely going to help improve aligner seating. Additional benefits, so pain is going to be reduced. It's also helping, I always like to tell patients also, similar to like a power plate at the gym, that the concept is that it's helping to get all your muscles working, is that this is also flushing out the blood. So if there are little pain mediators from the pressure of the aligners or the braces or whatever they're using something like this is just helping flush everything out. So it will reduce the pain, reduces refinements for sure by helping with those aligners getting seated properly, which will help with the treatment time. And in general, patients are less frustrated because you're taking less new scans and less refinements and less waiting time. It's also going to help increase bone remodeling. And then with retention, the bone density will be increased by that frequency as well. So conclusion from most of these studies on high frequency vibration is showing that even that 5 minute a day instruction, which is what the VPro 5, that's the amount of time it has to be used. It's 5 minutes out of the day versus the 20 minutes that was advised with the Accellident, that it's improving the accuracy with the accelerated aligner changes. It's also significantly reducing orthodontic pain and discomfort and helping with bone remodeling markers. So it is going to help the bone change shape faster, and that's why it is synergistic with the MOPs procedure as well. All of my MOPs patients get the VPro as well. And I usually bundle that together for $1,500 instead of doing $1,200 and $500. I just bundle them for those patients. So high frequency vibration in my office, $500 a device. That's for the VPro. Now with the V Plus, it's $750, and it is a premium adjunct. 99% of my patients in clear aligners purchase it. And I always emphasize all of the benefits because it's non-invasive, it's conservative. There's nothing, at all scary about this high frequency vibration device. It's FDA approved. Tracking is better. Treatment's going to go by way more seamlessly, more comfortable, and the aligners are going to fit better. If the aligners fit better, then everything is going to go the way it's supposed to go. So I'm going to present just one case with the VPro 5 appliance. So here's a 16-year-old male. He came in complaining that he can't even bite into a sandwich. So he's an open bite. He was a thumb sucker. He's class 1. And his alignment actually isn't bad. He just has this large open bite from canine to canine. So I talked to him about the VPro because my concern was that when he puts in his aligners, because he was treated with clear aligner therapy, that he's not naturally going to be biting down on those front teeth. And even with big attachments, I wanted to make sure that those teeth were always engaged. So I instructed him to rotate his VPro 5 to be able to bite on every single one of those front teeth individually with the appliance for at least a minute per tooth, and then to do everything together for 5 minutes. So not the most compliant patient, but here he is. And this is about 8 months later. So his hygiene isn't great either. You can see I've got these large horizontal beveled attachments. I have them both buccal and palatally on those upper incisors. And he's missed a bunch of appointments, but he came in and he was thrilled because he can now eat a sandwich and bite into a piece of pizza. And we still have ways to go, but the improvement is pretty stark with how much it's changed. And I do credit the VPro 5 for a lot of that because it helped engage those teeth that he wasn't naturally going to bite on at all and get those aligners to fit all the way on. So he's still tracking. So this is that change. So in 9 months, this is the change that we were able to get. So hopefully in another 9 months, he'll be done. So some of the catchphrases that I like to use with the VPro, I like to always stress that it's totally non-invasive. We live in a world where a lot of my patients will still ask me if clear aligner therapy is made of organic materials. And I try not to laugh, but we all know plastic is definitely not an organic material. So stressing the things like non-invasive, things that give patients confidence in the process and make them feel safe is really important. I do emphasize also that there's a soothing effect, that it's going to reduce the pain, and that it helps change the biology of the tooth movement. I like to say that more seamless treatment, things are going to progress really smoothly if you use it because it makes sure that those aligners are totally sucked onto the teeth. We're not going to have tracking issues. 5 to 7 day changes are more predictable. It always is going to depend on, again, what movement I'm trying to achieve. So 5 day changes, if more minor things versus bigger teeth that need to move. I stress that it's going to increase the efficiency and the efficacy of whatever the treatment I'm using is. And it does reduce appointments and refinements for sure. So only beneficial. There's nothing negative that can be said about high frequency vibration. It's 5 minutes out of the day. I have patients that even plug in that USB in their cars. I mean, we live in LA and there's a lot of traffic here. So I tell them, use it in the car, sit in traffic, use that thing whenever works for you. I do like to make sure that patients are doing it at night before bed because that is the longest continuous time that they're going to be wearing their aligners, after dinner until morning. But I have patients that use it throughout the day too. And if it doesn't bother them and it's going to make sure that those aligners are totally on, then sure, why not? So just an overall review of the benefits of high frequency vibration. So tracking is definitely improved. It will reduce pain. It's the most conservative adjunct that's available. It's going to increase and help prolong the bone remodeling biological markers. It's going to prolong that regional acceleration phenomenon effect, especially when combined with MOPs. So that synergistic effect. We're going to get accelerated movement with orthodontic forces, and that's again by ways of stimulating the cells in the periodontal ligament. And I like to say enhanced retention because we're going to help with bone density when they're using their retainers. So this device is good forever. So even without orthodontic force, it has positive benefits to it. And 5 minutes is it. 5 minute daily use is all that we need with that high frequency 120 hertz to get all of these benefits. So that wraps up my presentation. Thank you guys for tuning in and for listening. And that's my email. If anyone has any questions, feel free to reach out. And I'm happy to take any questions that you guys might have. So I have a question here that says, sorry, one second. Do you modify the treatment time based on use of MOPs while presenting to the patients? So usually I'll present them an estimated treatment time without bringing MOPs in, because I think numbers are really important for patients. So let's say I say it's, probably an 18 to 24 month case. And then I go on and I start presenting them, MOPs and what that procedure is and what it entails and how much shorter the treatment will be. So I'll tell them if it was going to be an 18 to 24 month case, it's definitely going to be it should be under a year if you're compliant. So I will do that. I will try to give them a comparison number and a goal so that they can properly make a decision, because I think it's really motivating to them when they hear it's going to be 2 years, especially for the adult patients. Because again, I don't really present it at all to a 12-year-old or a 13-year-old who are going through so many changes that their bone metabolism is acting in my favor. But for the adult patients, I think giving them a timeline like 18 to 24 months is very scary for them. They don't want to have to deal with it for that long. Some of my patients sometimes even say, let me start with the VPro and then I'll let you know. And within a week they call and they say, yep, we definitely want to do those perforations. So I think giving them a timeline, a target, really helps them. So thank you for that question. Okay, we have another question. Is vibration used for braces cases? So yes, vibration can be used for braces cases as well. Obviously, you wouldn't present that it's FDA approved as an aligner seater for that. But given all of the effects that it has at the level of the periodontal ligament, vibration can absolutely be used for any case across the board, because we know that it's helping with it's changing that bone chemistry. It's not as potent, let's say, as MOPs, but it's definitely something that's going to help. And with that flushing of the blood and everything in the bone, it's also going to help with pain for whatever device we're using. All right, another question. When you present a 2-year treatment in 12 months, do you MOP every 4 months? And do you charge full fee for MOP at repeat treatments? So no, I don't charge them more than once. When I charge them for MOPs at the beginning, it's all inclusive. At least in my practice, I really try not to nickel and dime my patients. I'm not charging for broken brackets. My fees tend to be on the higher scale because, again, it's more of a personal office where they're getting a lot of doctor time. So by keeping it small, by having 2 staff and myself, 25 patients in a day, we're really busy. And that's all I need. So I won't charge them again, but I will do MOPs as needed. So for the patient that I presented with the canine that wasn't responding well, after 3.5 months, I decided to repropel that specific tooth. So I just did a very localized MOP for him. It took about 5 minutes. I had to just do local anesthetic in that one little area, but I didn't do a generalized, I've never repeated the whole mouth. It's really been selective areas depending on the difficulty of movement and how the teeth are moving. So if some of the more difficult movements aren't being accomplished, then I'll definitely repeat it. Next question. How can I get access to those studies? I'd recommend that you contact your rep, and your rep can send you a PDF of all of the studies that I presented, especially the newer ones, all the ones that I think there were a few from November of 2018, the newer ones that are quite great. Any other questions? Can you use the Propel driver to place TADs too? Yes, you can. I have no experience with this yet, but the TADs, the Propel driver has all these different settings on it for torque and RPM speed. So the nice thing about it is that you can do it slower for TADs placement, and there are specific attachments that you can use as well to help place TADs with it. So quite a good investment to invest in that, the Propel driver for that. All right, I think that wraps it up. Thank you guys for your attention, and feel free to email me, Esther at drfeldmanortho.com, if you have any questions.